Hi everyone, how are you all? Hello guys,
Hello, sir. I'm good. How are you?
I'm good too, thank you. So today we gonna end the pharma of CVS, and from Monday we will go for the next module. We gonna start a next system. So let's wait around 2 to 3 minutes that the rest of the colleague will join too, and then we will go with our today's session. Okay. Hello guys, can you see my screen?
Yes, it's visible.
So, so we are going to start this day second of the CVS Pharma. So shall we start now?
Sure.
Okay. So any volunteer who wanna read it for me? Anyone?
Okay, so let me read. Which of the following is the initial cellular event triggering this response to the new medication? 54 years old man with non-ischemic cardiomyopathy comes to the office for a follow-up visit. He has been hospitalized frequently for acute decompensated heart failure and currently has dyspnea on mild exertion. The patient has also a history of hypertension and takes multiple medications. Blood pressure is 116/70 and the pulse is 72 and regular. Physical examination shows evaluated jugular venous pressure, basilar lung crackle, and lower extremity edema. Serum creatinine is 1.0, serum potassium is 4.2. 3 weeks after starting digoxin therapy, the patient reports symptomatic improvement. Which of the following is initial cellular event triggering this response to the new medication?
Okay. So in the scenario, they are asking that the patient come with decompensated heart failure, acute decompensated heart failure, and currently okay, doctors. So they are
Yes.
basically asking about the mechanism of action of digoxin. So can anybody tell me that digoxin work on which channel?
Potassium, right?
Sodium potassium increase.
Excellent.
Potassium.
It will act on a sodium potassium channel. ATPase. So let me draw it for you that it is like this is a cardiac membrane and this is sodium potassium ATPase. Okay, so basically digoxin will bind to the potassium side and will normally what the sodium potassium ATPases do, that it will excrete, yeah, or efflux, like efflux of sodium and influx of potassium will be done by this sodium potassium ATPases. So whenever a digoxin will bind to this channel, it will inhibit it, so the sodium will remain inside and the potassium will remain outside.
A little bit disturbing. Sometimes it's your voice gets so broken.
Okay.
So sorry. Mm, let's come again. Now you can see my screen, everybody.
Yes, we are. We see it. It's good.
Okay. So let's discuss it again. Sorry. So normally what happened, the sodium will move outside. Okay. So the sodium will move outside and this outside concentration of sodium will activate another channel called sodium calcium symporter, which will cause efflux of calcium and influx of sodium. Okay, doctors? Are you clear, everybody?
Yes.
Are you clear up till now? So,
So, doctor, is it the potassium that out or Sodium.
Which
I
one?
don't get it. You said sodium will be out and
Yes.
potassium. So
Potassium will come inside. Influx of
potassium
potassium.
influx and sodium
You,
efflux. Okay.
yes. Let me summarize it for you. Like
Okay.
there are two channels. One is sodium potassium ATPase, and the other is sodium calcium symporter. Okay, so it will usually work like efflux of sodium and influx of potassium. So whenever it is blocked by digoxin, so this whenever it is blocked by digoxin, that this symporter doesn't work properly, as a result of which the calcium will trapped inside, and we know that increased calcium means increased contractility. By this mechanism, digoxin usually work. Are you clear, everybody? Anyone with a question?
But but is it, when in this mechanism, right, it's gonna use sodium calcium exchanger, right?
Yes, sodium calcium symporter are exchanger. Another name for it are exchanger. Let me exchanger. So this is normally take place where and digoxin work on this sodium potassium ATPases. So whenever the sodium and potassium ATPases are blocked by digoxin, the sodium calcium exchanger is automatically shut down. Okay, doctors? So as a result of this, because this sodium and potassium exchanger will work in the sense like it will transport calcium outside of the cell and sodium inside of the cell. So whenever the concentration inside the cell of sodium increases, so it does not allow much of the sodium from outside to inside of the cell. So it is automatically shut down. Okay? Clear, everybody?
Yeah.
Can you
Anyone?
please repeat one more time?
Yes,
Little
yes,
bit,
I
please.
have to. There is a little bit tricky. Let me explain one more time for you. So
Is there,
what
sorry,
happened?
doctor, is there any way that, like, sometimes like you can draw something like a potassium in
Yes,
calcium,
yes, I
like
have to draw
something
it
like that?
for you. Like this is the membrane. So normally this is sodium. This is sodium is outflux and potassium is influx. Okay, and this is sodium calcium exchanger. Okay, so what happened? Digoxin will come here and block it. So whenever it is blocked by digoxin, the sodium will trapped inside. So the intracellular, because it is this type of exchanger will work on the concentration of ion, that whenever the concentration of ion is usually decreases inside, it is automatically start exchange of calcium sodium will move inside to the cell. So whenever the concentration inside increases, it is automatically shut down, as a result of which the calcium will stay inside. Okay, So calcium remain inside, and we know that calcium increase the contractility. By this phenomena, digoxin increase the contractility of the myocytes. Now you are clear, doctor?
Yeah, it's like the answer is gonna be B then.
Yes, yes. It is this due to this sodium potassium ATPases that it is usually blocked by digoxin, due to which the another exchanger is automatically shut down. Okay. So they are asking in the question that which one of the following is initial cellular event triggering the response to new medication. So we know that digoxin most probably work on which channel, sodium potassium ATPases, and it will decrease the efflux of which ion? Anybody?
If
Potassium.
it's gonna affect the potassium.
So, what happened here with us? Like I have told you earlier, that the concentration of sodium increases inside. Let me make it clear for you again. Like sodium concentration, sodium increases inside, potassium decreases inside, and calcium increases inside. Okay, so first happen, sodium increases inside, as a result of which the potassium decreases it is, and the secondly the calcium is increases inside. Due to sodium, the calcium increases. So sodium is occur first, and the calcium is occur as a second step. Now you are clear, doctors?
Yes, sir.
Yes.
So option A, they will show us that decreased sodium efflux from the myocardial cell. So it is correct as a first step, and increased intracellular calcium concentration is a second step, because it is occur due to blockage of sodium calcium exchanger. Okay? Clear, everybody? Anyone?
Yeah.
Yes. So they are asking about which one of the following is an initial cellular event triggering in response to this new medication. So most probably it is a sodium, a decreased sodium influx from the myocardial cells. Okay, doctor? Anyone with a question?
Understood, sir.
Okay. So let's move. So decreased sodium efflux from the myocardial membrane, and this is the option B is the second step, in which the calcium is stayed inside the myocyte, and that will increase the contractility. Okay, so let's move to the next one. Any volunteer?
Which of the following is the most likely response to this therapy? A 45-year-old man comes to the emergency department due to shortness of breath and fatigue that has progressed over the last 2 weeks. The patient was diagnosed with non ischemic cardiomyopathy 2 years ago and has not been adherent with physician visits and his medical regimen. Blood pressure is 106/58, pulse is 88 and regular. The patient appears uncomfortable when lying flat. Jugular venous pressure is elevated. Bibasilar crackles are heard on lung auscultation, and an S3 is present. There is 1 plus bilateral lower extremity pitting edema. Milrinone infusion is initiated. Which of the following is the most likely response to this therapy?
So thank you, doctor. So they are asking about a 45-year-old man with a heart failure and has a progressed means that there are worsening of the symptom that is occurred from the last 2 weeks. The patient is diagnosed with non-ischemic cardiomyopathy 2 years ago and has not been adherent to with physician visit and medical regime. So the blood pressure is usually 106 by 58 and pulse is 88 per minute and regular. The patient appear uncomfortable while lying flat means the patient has accumulation of fluid inside the lung that will lead to orthopnea. Okay, doctor. So they lead to and regulus venous pressure are elevated. Bibasilar crackers are here on the lung auscultation and S3 is usually present. There is +1 bilateral lower extremity pitting edema. Melranone is initiated. Which one of the following is likely response of this therapy? So this is the another MCQs in which they are asking about melranone mechanism of action. So what happened during infusion or with melranone infusion? Can anybody tell me that what is melranone? Anyone? Anyone?
Is it like a spironolactone and this?
It is a phosphodiesterase 3 inhibitor.
Okay.
Okay, doctor? So it
Yes.
is a phosphodiesterase 3 inhibitor, and I have told you earlier that phosphodiesterase will cause breakdown of which one of the solving intracellular component?
AMP.
Yes, excellent. Cyclic AMP. So what happened? This cyclic AMP will have two types of functions. First, it will act on the myocyte, and second, it act on the smooth muscles. And we know that smooth muscle is present in the vessels. Means myocyte in heart and in vessels. Okay, so this cyclic AMP. So what happened with us? The cyclic AMP level is usually increased with us, and due to this increase in cyclic AMP, that will cause increase intracellular calcium level with us, means trapping of the calcium inside the cell, and will lead to increase in contractility. Second, on the smooth muscle, it will stimulate cyclic AMP dependent kinase. So this cyclic dependent kinase will stimulate sarcoplasmic reticulum to increase the uptake of calcium. So whenever in smooth muscle they will decrease the level of calcium, and in myocyte they will increase the level of calcium by trapping it inside the cell. These are the two different types of function that is usually take place by cyclic AMP inside the smooth muscle and inside the myocytes. You are clear, doctor? Up to now? Doctors, are you with me?
Yes, doctor.
Anyone with a question? So what happened with us that due to this increased uptake of calcium by the sarcoplasmic reticulum, so the calcium level will become decreased with us in smooth muscle, and we know that calcium are responsible for contractility. So smooth muscle will become relaxed, and due to this relaxation, vasodilation take place. And this vasodilation are both as a venodilation and also arteriodilation. Means that systemic vascular resistance is also decreased and also venous return is also decreased as well. Okay? Okay, doctors?
Yes.
So they are asking which one of the following is most likely responsible for this therapy. So let us discuss the option. Yes, doctor? Are you have a question? Yes? Anyone? So let's discuss the options. So angioedema is the most common side effect associated with which one of the following anti-hypertensive medication? Can anybody name it?
That's the ACE.
Angioedema
ACE.
ACE inhibitor.
ACE inhibitor. Excellent. So milrinone is not an ACE inhibitor, and antiarrhythmic action is also not associated with milrinone because milrinone is a phosphodiesterase inhibitor, and avioventricular block is usually caused by which one of the which medications? Can anybody name it?
Beta
blocker?
blocker.
Beta calcium channel blockers and beta blockers. And decreased renal perfusion. Can anybody
ACE
name
inhibitor. ACE inhibitor.
is
ACE.
is
Yes, ACE.
Yeah, ACE
is
inhibitors.
is inhibitors. And increased right atrial pressure means that increased venous return. So it is usually a vasodilator. It does not cause venoconstriction. So this is also not. So the option here is correct. Is vasodilation. Okay, doctor. Clear, everybody?
Okay.
So let's move to the option.
So
Anyone
it's
with a
gonna be doing this mechanism through the by increasing cyclic AMP, right?
sorry, doctor, your voice is
Sorry.
so.
Oh,
Yes.
Oh my God.
Can you
Oh my
go
God.
again?
I'm just asking that. So this mechanism happening due to by increasing cyclic AMP.
Yes, yes, yes. The cyclic AMP I have told you earlier that it has two functions depend upon the cell. Like in myocyte, it will increase the calcium level, and in smooth muscle, it will decrease the calcium by increase the calcium uptake by the sarcoplasmic reticulum. So as a result of which relaxation of the smooth muscle take place, and due to this relaxation, when
So cyclic.
sorry, doctors. So let me explain it again for you. Are you with me, doctors?
Yes, yes.
Sorry. So the cyclic AMP, it will have two types of function depend upon the where it is usually present in myocytes, it will trap the calcium level and increase the calcium level, while in smooth muscles, it will decrease the calcium level by stimulating sarcoplasmic reticulum and increase uptake of the calcium, so cause relaxation of the smooth muscle and increase concentration, means contractility of myocytes. So as a result of this, vasodilation occur as a result of this. Okay, doctor? Clear now? Doctor?
Yes, sir.
Yes, thank you.
So, welcome. So, let's move to the next question. Any volunteer?
Yeah, I could read again maybe. If the cause of this patient's current symptoms is not corrected, which of the complications is most likely to develop? A 65 years old man comes to the physician after missing a follow-up appointment for congestive heart failure. He missed his appointment due to upset stomach that will not go away. A detailed history reveal disturbed color perception, anorexia, nausea, vomiting, and diarrhea that have worsened over the past 2 weeks. His congestive heart failure has thus far has been controlled effectively with multiple medications. If the cause of this patient's current symptoms is not corrected, which of the following complication is most likely to be to developed?
So now you guys gonna tell me that what is this drug they are asking about in the scenario? Anyone?
Is it the Jackson again?
Excellent. Now you are much closer. So it is a digoxin, because all these side effects are related to digoxin, and the most important side effect of digoxin is, which is a life threatening,
Yeah,
Arrhythmia.
potassium. Arrhythmia.
arrhythmia. Excellent. So all of the other options that are not associated with digoxin, like angioedema, are associated with ACE inhibitor. Bronchoconstriction is also associated with ACE inhibitor because of increased bradykinin level, and hypotension is occur with combined milrinone along with nitrates, and pulmonary edema is also not associated with digoxin. Okay, doctor? Clear, everybody?
Yeah. Thank you.
So these are the some of the, let me one more time tell you that side effect of digoxin. So digoxin have the following effect. It is the most important side effect are life-threatening arrhythmia due to increased potassium level, hyperkalemia. Number two, it have a GI side effects like nausea, vomiting, abdominal pain, and diarrhea. And it has neurological problems like fatigue, weakness, and fatigue, weakness, confusion, and color alteration. Okay, doctor. So these are the some of the side effects that is most probably associated with digoxin. Clear, everybody?
Yeah.
So let's move to the options. So we will go with arrhythmia. Excellent. So let's move. Anyone with a question? Shall we move forward?
Yes, we can.
So let's move to the next one. Any volunteer?
Which of the following diuretics would most likely improve survival if added to this patient's current regime? A 67-year-old man with non-ischemic cardiomyopathy comes to the office for follow-up. He recently was hospitalized for acute decompensated heart failure. The patient's symptoms have improved with multi-drug treatment, but he has persistent shortness of breath on mild exertion. He has a history of hypertension and hypercholesterolemia. Blood pressure is 115/70 and pulse is 66 per minute. There is a third heart sound on heart auscultation and mild lower extremity pitting edema. A recent echocardiogram showed a left ventricular ejection fraction of 30%. Which of the following diuretics would most likely improve survival if added to this patient's current regimen?
So let me tell you the scenario, and then let me tell you some of the drugs that are usually given to the patient with heart failure with reduced ejection fraction. So a 67-year-old man with non-ischemic cardiomyopathy come to the office for follow-up. He is recently hospitalized with acute decompensated heart failure, and the patient's symptom improve with multi drug treatment. The patient has shortness of breath on mild exertion. He has a history of hypertension and cholesterolemia, and the blood pressure is 115/70 and pulse is 66 per minute. There is a third heart sound on heart auscultation and mild lower extremity pitting edema. A recent echocardiogram show a left ventricular ejection fraction of 30. Normal, can anybody tell me the normal ejection fraction?
I think it's 45
50 to 70.
55 to
Yes, excellent.
65.
Most probably, the patient, we gonna take an average that the patient have an ejection fraction greater than 60%. Okay.
65.
So 65%, like 65% are, some books will say it is 65, some book will say it is 60. So the patient have a reduced ejection fraction. So it is a heart failure with reduced ejection fraction. Okay, half ref. So there are some medications that will increase the survival rate of the patient with reduced ejection fraction. Number one
Spironolactone.
is
beta blocker.
excellent spironolactone, and another one
SC inhibitor.
allopurinol. These are potassium sparing diuretics. And number second is, yes, doctor,
SC
ACE
inhibitor
ACE inhibitor and herbs.
and beta
These are
blockers.
the second one, and beta blocker. Excellent. Beta blockers like
bisoprolol.
metoprolol and carvedilol. Most probably these two are used, carvedilol or metoprolol. So these are the some of the drugs that will increase the survival rate are in a patient with reduced ejection fraction. So these drugs will always present in your mind while solving a MCQs related to reduce ejection fraction of a heart failure patient. Okay, so these are some of the drugs like metoprolol and carvedilol, ACE and herbs, spironolactone and allopurinol. So let us discuss that the patient has a very reduced ejection fraction. So, which one of the following will improve the survival if the patient current condition? Which one of the following diuretics will most likely improve the survival if if added to the patient current regime? So now you're gonna tell me that which one of the following diuretic we gonna add to the patient current regime. Anyone?
E.
Excellent. Because there are some of the uh, factors that also gonna tell us like spironolactone is an aldosterone antagonist, and we know that aldosterone has a effect on heart as well. Like, can anybody tell me?
Cardiac remodeling.
Yes, cardiac remodeling can be caused by an aldosterone. So this cardiac remodeling is very drastic. So we should have to prevent this by antagonize this aldosterone. And number two, aldosterone, number one is cardiac remodeling. Number second is myocardial fibrosis by deposition of collagen fibers. Okay. And number three is aldosterone has also caused vasoconstrictions through ACE, sorry, through RAS system and promote vasoconstriction and inflammation. So it will lead to endothelial dysfunction. So along with dysfunction, so along with the diuretic like function of spironolactone, the spironolactone will also antagonize the aldosterone. So it will have also minimize this effect as well, like cardiac remodeling, myocardial fibrosis, and endothelial. Due to this effect, the survival rate is usually increased in the patient. Now you are clear, doctor? So whenever in the option another type of potassium sparing diuretics like amiodarone and triamcinolone, these are also present. So we also gonna go with the option spironolactone because it is the only one which antagonize the aldosterone. These other like amiodarone and triamcinolone will not antagonize aldosterone. It will work on a specific channels called ENaC produced by aldosterone. That's why spironolactone is a very important drug that should be given to the reduced ejection fraction patient. Clear, everybody?
Yes,
Sir,
sir.
can you explain this cardiac remodeling? What do you mean by that? Like hypertrophy or left ventricular dilatation? What can you
Okay,
explain the
okay.
remodeling?
Let me show you by that. Like cardiac remodeling means can anybody that what happened in cardiac remodeling? Anyone?
Sir,
So
in cardiac remodeling, sir,
yes,
causes the heart muscle cells to grow larger, hypertrophy, and it's like there will be buildup of fibrous tissue, like you said. That's it, sir. Like if there is too much aldosterone for a long time, so it's gonna affect the heart, like due to excessive blood. I mean, there will be volume overload, and there will and the heart muscle will try to compensate it, and there will be hypertrophy. There
yes,
will
yes,
be
yes, 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 yes.
thinking of the
Like we have to. You gonna read it in Eisenmenger syndrome. Like what happened in it when there is excessive left to right shunt, the right ventricle will increase in size, means hypertrophy of the right ventricular will occur, and this will change the shunt from right to left. This is called cardiac remodeling. So let me tell you, you explain it very good, doctor. So let me explain it clear for you that what is cardiac remodeling? Cardiac remodeling is any type of structural and functional change occur in heart like in size, shape or function in response to any chronic stress. Can anybody give me an example of chronic stress?
Like high blood pressure, maybe?
Increase, yes, excellent. Like blood pressure. Like blood pressure and injury to the myocardium due to anything like accumulation of amyloids, yeah, or sarcoidosis or hemochromatosis that will lead to injury as well. So due to these stresses, either change in size of the heart like hypertrophy usually occur, change in function of the heart, either increase in contractility or decrease in contractility. Can anybody give me increase in contractility example? Like hypertrophy, hypertrophic cardiomyopathy, and decrease in contractility. Can anybody give me an example of it?
Heart failure, left side heart
Sorry.
failure.
Heart failure, excellent, and dilated cardiomyopathy, in which eccentric type of hypertrophy occur. Eccentric means that this myocyte will arrange in a series manner. That will the wall will become thin. And in hypertrophic cardiomyopathy, the myocyte will arrange in a parallel means in this manner, and there will be a concentric hypertrophy. So these are some of the information regarding cardiac remodeling. So cardiac remodeling is a process, molecular, cellular, or interstitial changes that will lead to ventricular size, shape, or function. Clear, doctor?
Yes, thank you very much.
So
Thank you.
welcome. So usually we have to prevent these functions, because due to this function there is increased risk of heart failure with us. So we have to decrease the cardiac remodeling by administering spironolactone, which will antagonize aldosterone. Now you're clear, doctor?
Yes.
Anybody with a question? Anyone?
Clear, doctor.
So let's move forward. Any volunteer?
Yeah, I can go. Which of the following is most likely to be increased due to the medication used in this patient? A 72-year-old man is brought to the hospital due to severe substernal chest pain and shortness of breath for the last several hours. The pain started suddenly when he was outside working in the garden. Medical history includes diet control, diabetes mellitus, and hypertension. Physical examination reveals bilateral crackles and third heart sound. ECG shows ST elevation in multiple leads. The patient is diagnosed with an acute myocardial infarction complicated by acute severe heart failure. He is started on dobutamine infusion and prepared for coronary catheterization. Which of the following most likely to be increased due to the medication used in this patient?
So they have given the patient dobutamine. Okay.
Okay.
So they are asking in the question, what is the mechanism of action of dobutamine? So can anybody tell me that dobutamine will act on which one of the following receptor?
Beta 1?
Beta 1 receptor, excellent.
Yeah.
Beta 1 receptor, also beta 2 as well. Okay.
Yeah.
So the beta 2 effect is slightly mild than beta 1. Beta 1 is more, and Beta 2 is slightly mild effect. So due to the beta 2, it will have a vasodilation effect, and due to beta 1, it will increase the heart
Contractility.
rate plus contractility. So why we gonna use dopamine in this patient with heart failure? Because the patient has an acute MI attack, and when the patient with an MI attack, we gonna have to quickly, as soon as possible, to revascularize to revascularize that place by either PCI method, percutaneous coronary intervention. So the first thing that we usually increase, so we gonna supply the oxygen to that place in increased amount, so the ischemia will not increases that much, and the necrosis should not occur there. Due to this, we gonna give the patient a dobutamine, so that the myocardial infarction should not be progressed further. So what happened in dobutamine? So I have already told you that what is the mechanism of action of dobutamine. It will increase the heart rate and contractility. So whenever the contractility increase, the blood supply to the heart increases, and increase oxygen supply.
Yes.
So which one of the following option is correct here? Any volunteer?
B.
Excellent. B. And
Yeah.
cardiac diastolic filling time, it is usually increased by beta blockers or calcium channel blockers, and peripheral vascular resistance should be increased by
ACE
vasoconstrictant.
vasoconstrictors, yes.
Vasoconstrictors, not vasodilators. And pulmonary capillary wedge pressure and right ventricular and diastolic pressure is also not associated with dopamine, because these both are decreased by dobutamine. Okay, clear everybody?
Yes.
So
So
let's move to the
dobutamine is
yes.
only given if the patient is prepared for PCI. If not, we cannot give because it will deteriorate the MI,
Because
right?
yes, no, it is also given in the MI condition, because the patient is also we cannot progress, we cannot be able to increase the progression of the MI, because the cell myocyte will be in ischemia, and that eventually goes to necrosis if efficient oxygen supply will not provided to them. For efficient oxygen supply to these myocyte will be provided by this dobutamine. Okay, okay, doctor? Because it will increase the contractility and rate as well. Clear, doctor?
Okay.
Okay, so let's move to the option. So, any question? Anyone? Shall we move forward?
Yes.
Yes.
So, let's move to the next question. Any volunteer? Sorry.
Age-related change in which of the following factors most likely accounts for this patient's symptoms? Should I go?
Yes, yes.
Yeah, age-related changes in which of the following factors most likely account for this patient's symptoms? The 79-year-old man is brought to the hospital due to confusion for the past 2 days. The patient has had nausea, decreased appetite, and poor oral intake for several weeks. He has also mentioned that everything around him has a yellow tint and he has no abnormal pain. Medical history includes long-standing heart failure with reduced ejection fraction and atrial fibrillation. Medication include metoprolol, digoxin, lisinopril, and apixaban. The patient is afebrile, blood pressure is 130/80, pulse is 58 per minute, abdomen is soft and non-tender. There is no rigidity or rebound, and no masses are present. Age-related changes in which of the following factors most likely account for this patient's symptoms?
So, according to the above scenario, there is a side effect of which drug? Along this metoprolol, digoxin, lisinopril, and apixaban. Can anybody tell me that which one of the following medication has these side effects?
This digoxin, yellow tint.
Excellent, digoxin, because of color alteration. And number two is there is nausea, decreased appetite, and increase anorexia. Means anorexia due to cellulite. So, can anybody tell me that digoxin is usually excreted through
Kidney.
kidneys? So anyone with a kidney disease, yeah, like CKD, so their renal clearance will compromised. So we know that the renal are responsible for clearing of digoxin. So whenever a patient has any type of decreased renal clearance, so the digoxin level will accumulates, and this accumulation will lead to toxicity. Okay, doctor.
So
So
basically, is this one like age-related changes? Is like due to chronic kidney disease? That's what we're gonna think.
yes, 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 because most probably the digoxin doesn't affected by intestinal absorption, because whenever there is intestinal absorption is the first step of drug. Whenever a drug is usually absorbed through intestine, it will show its effect. When no absorption are usually occurred, the drug will does not show any type of side effect. So this option is not fit in the category. Number two is liver enzyme activity. Number two, so digoxin doesn't have any type of liver toxicity. And muscle mass, as we know that the muscle mass is usually affected by which drug? Can anybody tell me?
Amir,
Which one?
Statins.
oh, certain.
Statins, because it will lead to rhabdomyolysis. And number three is plasma protein binding. There are much drugs that will increase in the plasma protein binding and will cause toxicity, but digoxin doesn't have that type of property. So the only option here, because with age the renal clearance, we know that with increasing age the renal clearance will become decreases due to decreased number of nephrons with us. Oh, clear, doctor?
Yes.
Yes.
So
Like
a
the point.
slight increase, So let me clear it first. So a slight increase in digoxin will show its side effect because of decreased renal clearance. Okay, doctors?
Yes.
So let's move to the option that anyone with a question?
I have a question, yes. So,
Yes.
like a majority question is gonna come from the exam on the exam. It comes in the digoxin or side effect or mechanism of action.
Sorry, doctor, your
What I'm saying that we got how many questions like what's the percentage, because most of the question looks like the Jackson, like all the side effect and mechanism of action.
because
So what I'm saying,
digoxin will have a very narrow therapeutic index. And a small increase or whenever it will given a little bit decrease than its therapeutic dose, then it doesn't work with that. It required under its therapeutic dose, and whenever a small increase is occur or little bit increase than its therapeutic doses, it will cause toxicity. These are present in two types of drugs. First is digoxin and second is present in lithium, which is used in bipolar disorders. So doctor, can you go again with your question?
no, I was just saying that asking that looks like a too many question just pertaining to the Jackson. I was just wondering, like we're gonna be getting a lot of question at the exam.
Yes, you should go through the digoxin very, very, very much because it is a very important topic and very examiner friendly, because everyone should talk about digoxin because the digoxin is with increased number of side effects. They are nowadays also used in heart failure patients in this era as well. So they are asking about the digoxins in lot of questions. The lot of questions. So with a very little study, like digoxin will barely take around 2 to 3 hours, and it will clear around 13 to 20 MCQs, because in every aspect they will ask you a question related digoxin, because digoxin can cause life threatening arrhythmias due to hyperkalemia, and it will also cause, because if the patient is present in hypokalemia, it will also increase digoxin toxicity because it not have a competition with digoxin. So the digoxin topic is very important. You should go through this topic really comprehensively. Clear, doctor?
Yes, thank you.
So let's move to the next question. Any volunteer? Anyone?
Which of the following medication will most likely improve survival in this patient? 68-year-old man comes to the office due to several weeks of progressive exertional dyspnea and lower extremity edema. Medical history is significant for non-Hodgkin lymphoma, which is the remission after chemotherapy 8 years ago. Blood pressure is 126/76 and pulse is 88 per minute. Physical examination revealed bibasilar lung crackles and 1 plus bilateral lower extremity edema. Echocardiography show biventricular dilatation and left ventricular ejection fraction of 35%. Stress myocardial perfusion scan is negative for inducible ischemia. After initial stabilization, long-term use of which of the following medication will most likely improve survival in this patient?
So now you're gonna tell me, doctor, that I have already told you that with reduced heart failure, with reduced ejection fraction, which one of the following medication should be used? Now you're gonna tell me one by one. First is spironolactone
Yeah, Pyrimethamine,
and
Allopurinol,
elepranon, and number two is
ACE
inhibitor.
inhibitor,
ACE
and
inhibitor and herbs,
Yeah,
and number three is
beta blockers.
metablock,
beta
metoprolol,
blockers, metoprolol, excellent,
and
Davidoff.
option C, carvedilol.
carvedilol. So in this option, in this medication, which medication is usually present in the question?
Option C,
Option C, excellent. So we gonna go with option C and then discuss it. So good. So it is a
Sir, I have a
carvedilol.
question. Is
Yes,
the
yes,
class
yes.
being yesterday's recording is not yet uploaded because I couldn't attend the whole class, so I just want to ask when will that be uploaded?
So I will ask to the team and tell the team that it should be uploaded as soon as possible, and I think they are going to upload them today.
Okay,
Or
and also this class is also being uploaded. Will be uploaded today.
yes, yes, yes. Both of them will be uploaded together.
Thank you so much, sir. Jazakallah. So sorry to
Okay.
interrupt.
No problem. So, anyone clear?
Yes, sir.
Anyone with a question?
No,
Yeah.
sir. Understood.
Oh, yes, yes.
Yes, yeah, we can
Somebody
move
have a
forward.
question?
Yeah, thank you.
No. So let's move to the next question. Any volunteer? Any volunteer?
This additional medication predominantly acts on which of the following nephron segments? A 71 years old woman comes to the office for follow-up. She has history of systolic heart failure and was hospitalized 2 weeks ago for an exacerbation which was treated with intravenous diuretics. Since discharge, the patient has been taking oral diuretic and says her shortness of breath has improved. But she is now experiencing muscle weakness and cramping. Blood pressure is 128/72 and pulse is 80. Physical examination shows mildly decreased muscle strength in lower extremities. Laboratory evaluation reveals a serum potassium level 2.2. The patient receives potassium supplement, which improve the weakness. Another diuretic is added to her medical regimen to help prevent this adverse effect in the future. The additional medication predominantly acts on which of the following nephron segment?
So now you're gonna tell me that which medication they are going to add.
Is maybe Lasix or furosemide? Because the
So
spironolactone usually, or maybe spironolactone.
yes, yes, you because the patient is gone into the hypokalemia.
Hypokalemia, yes.
So we gonna give them a potassium sparing diuretic
Yes,
along
spironolactone.
with loop or thiazide diuretic. They doesn't mention the diuretic like thiazide or loop. And after that they have give another diuretic which have a medical regime to help to prevent the adverse effect of hypokalemia. So most probably they have give them either spironolactone R. Allopurinol, R. Amiodarone, R. Triamcinolone. Because all of these are potassium sparing diuretic. These are aldosterones. The first two are aldosterone antagonists, and this amiodarone and triamcinolone are ENaC blockers. Both of these are usually present in which portion of the nephron? Can anybody tell me?
Here.
Distal in the collecting duct.
Excellent. Principal cells of collecting ducts. So in the nephron, which portion is usually a collecting duct? Can anybody tell me?
Collecting duct is gonna be there is
F.
F. Excellent. So let me discuss these options one by one. So in option A means that it is a proximal convoluted tubule. It is usually a descending limb of loop of Henle, and this is ascending limb of loop of Henle, and this is collecting duct, and this is sorry, this is distal
Convoluted tubule.
distal convoluted tubule, and this is collecting duct. Okay, so in proximal convoluted tubule, usually acetolamide like work like carbonic anhydrase inhibitor work on proximal convoluted tubule. Another one are called osmotic diuretic like mannitol, which is usually work on which portion? Descending limb of loop of Henle. Like in option B, osmotic diuretic like mannitol work on option B. Acetolamide will work on option A, and on option D, loop diuretics usually like furosemide work on option D, and on option E, thiazide diuretic usually work, and on option F, potassium sparing diuretic usually work here. Clear, everybody?
yes.
So let's move to the option. On option F, clear, everybody?
Yes, thank you.
Anyone with a question? Shall we move forward?
Sure,
Yes, sir.
Yes, sir.
Yes. So let's move forward. Any volunteer?
The addition of metolazone is likely to assist in treating this patient because of which of the following effects of furosemide. A 56-year-old woman comes to the clinic for follow-up of heart failure with reduced ejection fraction. Over the last 3 months, the patient has been hospitalized twice due to acute decompensation of heart failure that required treatment with intravenous furosemide. Since her most recent discharge, she has been taking high doses of oral furosemide, but she continues to have progressive lower extremity edema and weight gain. Serum creatinine is 1.2 and serum potassium is 4.1. The patient is started on metolazone. The addition of metolazone is likely to assist in treating this patient because of which of the following effects of furosemide.
So they are asking in the question that a patient with reduced heart failure with reduced ejection fraction. Okay, doctor? So they are asking that they have given what one with furosemide. So furosemide is a loop diuretic. Okay, doctor? So what happened here? Let me draw an nephron for you so that it will eventually clear for you. So this is a Bowman capsule. This is so most probably the furosemide work here by inhibiting sodium potassium 2 chloride channel. So as a result of this, the sodium concentration inside the tubule increases, and this sodium will move to the distal convoluted tubule where another type of sodium channel, like let me draw here, where another type of sodium channels like sodium chloride channel that will increase its function and increase sodium absorption. So we are going to also block this sodium chloride channel that are usually present in a distal convoluted tubule. So we know that metolazone is a thiazide diuretic which is usually work on a distal convoluted tubule. So the metolazone will inhibit this sodium chloride channel, and as a result of which this sodium will not absorb in a distal convoluted tubule and the symptom in a heart failure patient is improved. Clear, everybody?
Yes, sir.
Guys, are you with me?
Yes.
So both of these will increase their effect, means they both have a additive type of effect. Additive means both will work on a nephron and both will have the same function that will decrease the sodium absorption and increase sodium excretion in the urine by decrease absorption through the by the tubular epithelial cell. So which one of the following option is correct regarding metolazone function? So we will go with one by one. So in option A is increase calcium delivery to the sodium channel. So usually the thiazide diuretic will cause increase absorption of calcium, and it is usually a diuretic usually to treat hypertension in osteoporotic individual because it will increase the calcium absorption here. Number two is usually increase sodium delivery to the distal tubule. So it is correct option here. With option C, each in increased tubular reabsorption of bicarbonate, it is not correct. Regarding to the metolazone, and option D is increased tubular reabsorption of uric acid, it is also not correct. Reduced tubular reabsorption of glucose, it is usually by some of the anti TB drug like sodium glucose transporter 2, yeah, like empagliflozin. These will usually reduce the tubular reabsorption of glucose and reduce tubular reabsorption of potassium. It is usually caused by furosemide, like sodium potassium 2 chloride channel inhibitor. Clear, everybody? Anyone with a
Yes.
question? So
Yes,
we will go with the option B. Anyone with a question regarding this scenario? Shall we move forward?
Yes, sir.
Yes. Sorry. So let's move to the next question. Any volunteer?
Which of the following medications would be most effective for lowering this patient's blood pressure without worsening his ECG abnormalities? A 62-year-old man comes to the office for follow-up of hypertension. He was diagnosed with hypertension 10 years ago and has been treated with a number of different medications. However, the patient has had to discontinue several medications due to side effects such as dizziness, palpitation, and headaches. Currently, he takes ramipril and chlorothalidone and is tolerating them well. Blood pressure is 160 over 92 and was 158 over 89 at his most recent prior visit. ECG shows sinus bradycardia, 55 beats per minute, with PR interval prolongation, 280 millisecond. Which of the following medications would be most effective for lowering this patient's blood pressure without worsening his ECG abnormalities?
So we know that we required a drug. So they are asking in a question. Let me summarize it for you. They are asking about a drug that decrease blood pressure with us without causing ECG changes. So now you guys gonna tell me that in the above option, which one of the following drug has only effect on vessels and no effect on heart? Can anybody tell me? Anyone?
Nifedipine. Nifedipine.
Excellent, nifedipine, because it has only work on a vascular smooth muscle. It doesn't have any effect on a heart. So ECG is usually produced by any effect on a heart. So diltiazem and verapamil is a non-dihydropyridine calcium channel blocker. These are usually can cause prolongation of QT interval along with metoprolol, which is a cardio selective beta blocker, and it will also increase the QRS and ST segment prolongation. And sotalol, as we discussed yesterday, the sotalol will cause QT prolongation. Clear, everybody?
Yeah.
So let's move to the option. So this is a very clear cut question. They are asking about a drug they have no effect on the heart. So nifedipine is the only drug which has only work on vessels, not on heart. Shall we move forward? Or anyone
Yes.
with a question? So let's move ahead. Any volunteer?
Which of the following was most likely prescribed to treat this patient's hypertension? A 77-year-old man comes to the office after he was found to have a high blood pressure during a health scare. The patient denies any medical problem and feels proud that he has not needed to see a doctor for many years. His blood pressure is 170 over 70 and pulse is 74 per minute. Other physical examination findings are normal. Patient is started on a medication to treat his hypertension. During this follow-up visit, 3 weeks later, he reports bilateral leg swelling and he has no chest pain, shortness of breath, and abdominal symptoms. His blood pressure is 135 over 65 millimeter of mercury and pulse is 80 beats per minute, and cardiopulmonary examination is normal. And there is bilateral symmetrical 2+ thickening lower extremity edema. Laboratory studies show serum creatinine 0.8 milligram per dl and urinalysis is negative for proteinuria. Which of the following was most likely prescribed to this patient's hypertension?
So they are asking about a 77-year-old man that have a high blood pressure, and this patient are now presented with a blood pressure of 170 by 70 and a pulse is 74. Other physical examination is normal and he is treated with some medications for his hypertension. During this follow-up visit 3 weeks later, he reports a bilateral edema. Okay, doctors, there is no chest pain, shortness of breath, or abdominal pain. Abdominal symptoms means that the patient doesn't have any type of heart failure symptoms. Heart failure symptoms means that if the patient edema is usually occurred due to heart failure, so it is a generalized type of edema which is usually occur in pulmonary system as well, peripheral edema as well, and ascites as well. So the patient has only peripheral edema, not central or pulmonary. So the blood pressure, his blood pressure is 135 by 65 and pulse is 80. Cardiopulmonary examination is normal, but there is a bilateral symmetrical +2 pitting edema in the lower extremity. Laboratories show serum creatinine 0.8 mg per deciliter and urine analysis is usually negative for proteinuria. Which one of the following is most likely prescribed to treat this patient? So now you're gonna tell me that what is the in which medication usually cause this peripheral edema? Can anybody tell me?
Calcium channel blocker.
Yes, channel.
Excellent. Calcium channel blocker. Can anybody know the reason why it is usually happen?
Increases the capillary pressure.
Dilatation.
Excellent. It is usually occurred as a precapillary dilation. So this precapillary dilation will lead to extravasation of extravasation into the interstitium. This extravasation will lead to edema. With respect to, there are some of the drugs that will cause post capillary venodilation that will decrease the side effect of calcium channel blocker. Can anybody name these drugs that will cause post capillary venodilation? Yes, doctor?
Amlodipine.
Amlodipine usually cause precapillary dilation. Post-capillary venodilation is usually caused by ACE inhibitor or ARBs. So these will usually can counteract the calcium channel side effect in peripheral edema patient. So usually they are given in combinations. So the peripheral edema will subsides. Okay, doctor. So let's discuss the option one by one. Are you clear up till now? Anyone with a question? Anyone?
No.
So amlodipine will usually can cause peripheral edema, which is usually a correct option here. Peripheral edema. So alepranon hydrochlorothiazide is usually that will subside the edema. It doesn't cause edema. So it is used for treatment of edema. These both option B and C, and ramipril. And can anybody tell that what is torsemide? Can anybody? It is a loop diuretic. Another than furosemide and valsartan and ramipril, these can cause post-capillary venodilation and can counteract the effect of calcium channel blocker and can co-administer along with calcium channel blocker to reduce the peripheral edema. Clear, everybody?
Okay.
Anyone with a question? So, these are some of the explanation regarding peripheral edema caused by calcium channel blockers, because they will increase the calcium, decrease the calcium level, and as a result of this decrease they will cause vasodilation. Okay, doctor? They will eventually lead to edema. Only peripheral edema is associated with calcium channel blockers. So, anyone with a question? Anyone?
No, we can move forward.
So, let's move forward. Any volunteer? Anyone?
Which of the following medications should be avoided in this patient? A 64-year-old man comes to the office to follow up of hypertension. At the last 2 visits, his blood pressure was persistently elevated. The patient has been treated with lisinopril for the past 5 years, but his other blood pressure medications have been changed several times due to various adverse effects. Medical history is significant for type 2 diabetes mellitus, coronary artery disease with stable angina, and moderately increased albuminuria. Blood pressure is 145/87 and pulse is 70 per minute. BMI is 31. Physical examination shows trace bilateral lower extremity edema. ECG is unremarkable. Serum's laboratory results are as follows: sodium 138, potassium 5.3, chloride 104, bicarbonate 24, calcium 9.5, creatinine 1.0. Review of the patient's medical record shows similar serum laboratory results 6 months ago. Which of the following medications should be avoided in this patient?
So we should go with the anyone. So a 64-year-old man with hypertension, at least last 2 visit, his blood pressure was persistently elevated, means that his BP is continuously elevated, and the patient has been treated with lisinopril for the past 5 years and other blood pressure medication and have been changed several times during various side effects. And medical history is significant for type 2 diabetes mellitus and coronary artery disease with stable angina. Moderately increased albuminuria, BP, blood pressure is 145/87 and pulse is 70 per minute. BMI is 31, means the patient is obese, and the physical examination showed transbilateral lower extremity edema. ECG is unremarkable. So let's discuss. The sodium is present normally. Potassium is normal level is 3.5 to 5.5. So it is present on the upper border.
Doctor, isn't it 3.5 till 5?
3 point, some book will say it is from 3.5 to 5.5. Some book will say it is from 3.5 to 5. So usually potassium will have a very narrow, like a slight increase in a potassium level, you should correct like 5.6 or 5.7. You should correct them immediately. because it will lead to a life-threatening edema, arrhythmia.
Arrhythmias.
Life-threatening arrhythmias. You should give these patients a cocktail that contain calcium gluconate, insulin, and alpha agonist. Okay? Okay, doctors?
Okay.
So the potassium level are usually present on its upper border, and a slight increase in potassium level can lead to arrhythmia. So we should avoid these drugs like potassium sparing diuretics because it will lead to hyperkalemia and can lead to life threatening arrhythmias. Clear, everybody?
Yes. D.
So let's move to the options that which one of the following is a potassium sparing diuretic.
D.
So which one of the following is a potassium sparing diuretic? Excellent, doctor. Option D,
Alprazolam.
because
None. Yeah.
allopurinol and spironolactone, both of them are potassium sparing diuretics. Clear, everybody?
Yes.
Yes. So let's move to the next question. Any volunteer?
Which of the following is the best treatment for the patient's hypertension? The 60-year-old man who was recently diagnosed with hypertension comes to the office for follow-up. He was treated with lisinopril but stopped a week ago due to dry nagging cough. Past medical history is notable for type 2 diabetes mellitus with moderately increased albumin but normal creatinine chloride. His other medications include metformin and rosuvastatin. The patient doesn't smoke or drink alcohol. His blood pressure is 150/92. BMI is 31. Physical examination including the heart and lung is unremarkable. Which of the following is the best treatment for the patient's hypertension? So it looks like an 8 centimeter was, oh, okay, side effect happened.
So it
Yeah.
is usually okay, doctor. So it is a ACE inhibitor. Inhibitor side effect. And what is the most common side effect of ACE inhibitor?
Dry cough.
It's like
Dry cough.
Dry cough,
Angioedema.
angioedema. These are the side effects that are usually caused by ACE inhibitor because we know that ACE are responsible enzyme are responsible for degradation
But
of
bradykinin.
bradykinin. Excellent. And which other substance? Substance B.
Angiotensin.
Yeah.
Substance B. So these bradykinins are responsible for angioedema and dry cough as well. So whenever a patient develop these symptoms, you should go for another drug which have a similar function like ACE inhibitor and how doesn't cause dry cough and angioedema. Can anybody name it?
Valsartan.
ARBs.
ARBs.
ARBs. So they are asking that which one of the following is the best treatment for this patient because ACE inhibitor and ARBs are usually same functions.
Yes.
So why we are not given the patient first ARBs? Why we start our antihypertensive treatment with ACE inhibitor, not with ARBs? Can anybody tell me why? Because we know that ACE inhibitor have a side effect like dry cough and angioedema. Then why we give this patient ACE inhibitor? Why not ARBs?
Because it's like an initial step, right? I don't know. It's converting from
Inhibitor, in AC inhibitor, we are inhibiting angiotensin. We are not like angiotensin. One is not converting in angiotensin
There
2.
is a very important step that you should know,
But in ERS, like it's the
that
angiotensin 2 is
while
present, but
treating
the
the patient, the ACE inhibitor are really cheap and
Yeah.
ARBs are expensive.
Yeah.
So you should give the patient a cheap type of drug that doesn't affect financial status of the patient. You should always think about the patient financial status, that either, so the ARBs are used because they are really cheap and ARBs are expensive. That's why we start first with ACE inhibitor, and when ACE inhibitors cause any type of side effect in a patient, then we shift to ARBs. These are the only difference between these two. Okay,
I was
doctor?
going to say that, but I thought you want the fancy course. Yeah.
No.
Okay.
Because when you come to the hospital setting, you should
Yeah.
to worry about everything like financial status of the patient, not give the patient too much expensive medication. Okay?
Yes.
These
Right.
these are come under the medical negligence. So you should think
Yes.
about everything. So we gonna start with ACE inhibitor, and after ACE inhibitors, if it cause side effect, we will go with ARBs, because both will cause afferent arterial vasodilation. Okay, doctors? Clear everybody?
Yes, thank you.
So let's move with which one of the option is correct?
Valsartan. E.
Valsartan. Excellent. So let's move to the next one. Anyone with a question regarding this scenario? Shall we move forward?
Yes, sir.
Okay.
Yeah.
Let's move to the next one. Any volunteer? Anyone?
I think we should be quick, after 1, 2, 3, then somebody has to jump.
Yes, doctor?
Which of the following intracellular changes is most likely responsible for improvement in that condition? A 40-year-old female with a history of depression and hypertension is brought to the ER after being found being abstinent in her apartment. She is hypotensive and bradycardic. On physical examination, intravenous glucagon is administered and her condition improves. Which of following intracellular changes is most likely responsible for improvement in her condition?
So they are asking about a 40-year-old female with a history of depression and hypertension is brought to the ER after being obtended in his apartment, being unconscious. She is hypotensive and bradycardic on physical examinations. These are the side effects of which drug? Can anybody name it?
Beta blocker, maybe.
Beta blockers. Excellent. So intravenous glucagon is administered, which is the drug of choice in beta blocker toxicity.
Okay.
Okay, doctors? And her condition, which one of the following intracellular changes is likely responsible for her improvement? Can anybody tell me that how glucagon usually work on the heart?
Increases cyclic MP.
Excellent. Through which pathway?
Is increased protein kinase.
By increasing G as
GS.
coupled receptor
Progress. Increase protein
in
progress.
cardiac myocytes,
Mm.
not through beta receptor, because beta receptor are blocked by beta blockers. So it will work through GS coupled receptor in a myocyte that will increase cyclic AMP, and this cyclic AMP activates by adenylate cyclase that increase cyclic AMP level independent of beta adrenergic receptor. Let me show it clear for you. Like increased cyclic AMP will lead to increase intracellular calcium level. This calcium level will lead to increased heart rate, and this heart rate will increased means increased heart rate. So the bradycardia will become decreased with us and increase blood pressure with us. So hypertension will become, the patient will become normotensive. Okay, doctors?
Yes.
I have told already to you that the cyclic AMP in monocytes will trap the calcium channel inside, and we know that trap the calcium inside, and this calcium will lead to increased contractility and also increase heart rate as well. Clear, everybody? Clear, everybody?
Yes.
Sorry, doctor, can you go on this again?
Yes. So let me clear it for you. So glucagon will stimulate adenylate cyclase enzyme that will increase cyclic AMP level. Okay, doctor? So this cyclic AMP will trap calcium inside myocytes. So we know that whenever the calcium level is increased inside, it will increase the contractility and heart rate as well. So by this way, it will treat the heart, because the beta blocker will already occupy the beta receptors. So whenever you should give them any beta agonist, so it doesn't work because the beta receptor is already occupied by these blockers. So we usually give them glucagon because it is a drug of choice, because it doesn't work on beta receptor, it's work on GS receptors that increase adenylate cyclase, which increase cyclic AMP, that trap calcium, and as a result of contractility and heart, both hyper BP is increased and also heart rate is increased. Clear, everybody?
Yeah, so clear. Thank you so much.
Welcome. So which one of the option is correct?
D.
D. Excellent. Anyone with a question? Yes. Shall we move forward?
Yes.
Yeah.
So let's move to the next question. Any volunteer?
During the first 7 days of therapy, the patient which of the following structures was most likely affected by downstream effect of enalapril and is therefore responsible for this patient renal response? 44-year-old man comes to the office for routine checkup. Past medical history is significant for hypercholesterolemia, which he was controlled through diet. His father died of myocardial infarction at the age of 56, and his mother, who is still living, has a history of a stroke. On physical examination, the patient's blood pressure is 160 over 100 and heart rate is 70. He is started on enalapril. During the first 7 days of therapy, the patient glomerular filtration rate adjusts as shown in the graph below. Which of the following structures was most likely affected by the downstream effect of enalapril and is therefore responsible for this patient renal response?
So let me draw a nephron here for you. So you should effectively. So this is the glomerulus. This is proximal convoluted tubule. So there is coming. Sorry. There is some mistake. Let me draw it again. So we should go with a single one here. So the afferent arteriole come here and will move like this and then move into the efferent arteriole and then vasa recta here and then precapillaries and then again move into the venules. Okay, doctor. So like this. So can anybody tell me that enalapril will work on which portion of the nephron?
Efferent, right?
Afferent arteriole, and will cause vasodilation of it. And a drug of choice for hypertension in diabetic and hypertensive individuals. Okay,
Yes.
so let's move to the options. So which enalapril will work on which portion of the nephron?
Efferent.
Afferent arteriole. So it is a very simple question. Anyone with a question?
No.
So let's move forward. Any volunteer?
Which of the following best describes the mechanism of action of this medication? A 54-year-old man comes to the office due to new onset muscle cramps. The patient has a history of hypertension and was started on hydrochlorothiazide 4 weeks ago. Blood pressure is 138 over 86 millimeter of mercury and pulse is 78. Examination shows no abnormalities. Based on his most recent laboratory result, triamterene is added to the current therapy. Which of the following best describes the mechanism of action of this medication?
So they are asking about the mechanism of action of triamterene. Can anybody tell me in which class triamterene usually come?
Potassium sparing.
Potassium sparing. Excellent. So potassium sparing diuretics, and it work on which one of the following channel?
ENaC channel.
ENaC. So this ENaC are usually present on which cell? Can anybody tell me?
On the
Principal cell.
basolateral.
Principal cell. Let
cells.
me made it clear so that you will efficiently memorize it. Like this is a blood vessel. Let me draw it in red. So this is a blood vessel, and this is a luminal cell. Sorry, this is a epithelial cell of the tubule, and this is a tubule with us. This is a tubule. This is a epithelial cell, and this is a blood vessel. This is a vessel with us. Okay, so ENaC is usually present here between the epithelial cell and luminal cell. Sorry, between tubule and epithelial cell. This is ENaC. This will absorb sodium from the lumen into the epithelial cell, and here another type of cell called sodium potassium ATPases, which will transfer potassium here and move sodium into the blood. This all process is oriented by aldosterone. Aldosterone will increase the production of ENaC, and ENaC will eventually absorb sodium, and this sodium will then move into the blood by sodium potassium ATPases. There is another kind of channels. Can anybody name it? Rome,
The
renal.
hydrogen.
Can anybody spell it? Rome, renal, outer, medullary, potassium channels. So these are also produced by this aldosterone, and they will eventually shift the potassium out of the epithelial cell into the lumen. So they will, by this mechanism, the aldosterone will cause hypokalemia. Clear, everybody? Anyone?
Can you repeat that once more, please? Thank you.
Let me. So normally what happened that normally aldosterone come and aldosterone increases production of ENaC along with, let me, aldosterone increase production of ENaC and ROMC. The ROMC only work when there is a potassium that are usually present in the epithelial cell and push it into the tubule. So ENaC, what usually ENaC do? ENaC will absorb calcium, sodium from the tubule into the epithelial cell. From the epithelial cell, this sodium potassium ATPases will push potassium from the blood and sodium into the blood. As a result of this channel, the potassium level increases in the epithelial cell, and this ROMC will then activated, and this ROMC will push the potassium into the tubule, and this will lead to the hypokalemia. Clear? So the triamtrene will come and it will block this ENaC, which is the initial step in absorption of sodium. So whenever the sodium does not absorb from the tubule, this sodium concentration will not increase in the epithelial cell, and this ATPase will not activated. As a result of this, the potassium will become spare in the blood. So by this mechanism, triamtrene will spare potassium. Clear, everybody?
What was the last line? The triamterene will block ENaC.
ENaC, and whenever ENaC is blocked, the sodium does not come into the epithelial cell, and the sodium potassium ATPases does not transfer sodium into the blood and potassium into the epithelial cell, as a result of which the potassium will spare in the blood,
Oh,
and
okay,
by
sir.
this mechanism it will prevent
Hyperkalemia.
hypokalemia. Okay, doctor?
Yes, sir.
So
Understood.
we usually use triamtrene along with thiazide or loop diuretics to prevent hypokalemia, because triamtrene does not have a side effect like gynecomastia and other related side effects. Clear, everybody? Clear, everybody?
Yes, sir.
Yes.
So which option is correct? Now you're gonna tell me. Blocking
A.
A.
option.
Lower
Excellent.
natural.
Are you clear, everybody? Anyone with a question? Anyone? Shall we move forward?
Yes.
So let's move to the next one. Any volunteer?
Which of the following medications was most likely used in this patient? 72-year-old man is brought to the emergency department with waxing and waning chest pressure over the past several hours. The patient says he occasionally gets a similar sensation that lasts 5 to 10 minutes when he walks briskly up the stairs. Medical history is significant for hypertension and hyperlipidemia. He has been non-adherent with prescribed medical therapy and follow-up visits. The patient has a 25-pack a year smoking history. Blood pressure is 211 over 105 millimeter mercury and pulse is 88 per minute and regular. Chest examination reveals no heart murmurs and the lungs are clear. ECG shows sinus rhythm and non-specific ST segment changes. A medication is administered intravenously and produces the following hemodynamic effects compared to baseline. Stroke volume unchanged, systemic vascular resistance decreased, heart rate decreased. Which of the following medications was most likely used in this patient?
So they are asking about a patient that has come to the hospital with hypertensive emergency.
See, yeah.
Okay, his blood pressure is 211 by 105, which is usually a very much high pressure. We have to decrease this blood pressure as 25% in first hour and then slowly decrease the blood pressure eventually. So they have given a drug that have unchanged the stroke volume and systemic vascular resistance is decreased and heart rate is also decreased. Which one of the following medication is given to the patient? Can anyone with the correct option?
Hydralazine.
Hydralazine.
Hydralazine. Can
Labetalol.
anyone with the other option?
Labetalol.
Labetalol.
Labetalol. Anyone with another option?
Nitroprusside.
Leprolol.
Nitroprusside. So let's discuss one by one. So hydralazine is usually
Direct vasodilator.
Arterial vasodilator.
arteriovasodilator. Arteriovasodilator. So it will only decrease the systemic vascular resistance. It has to do nothing with heart rate. And second, it will change the stroke volume. Okay.
Okay.
So hydralazine is not correct here. So let's move to the labetalol, which is the first line medication that is usually used in hypertensive emergency. Labetalol. Labetalol is a
Beta blocker.
non-selective beta blocker. It has beta 1, beta 2, and alpha 1 antagonist effect. So we know that beta 1 are present in
Blood vessels.
SA node, AV node, and myocytes as well. So as a result of this, it will decrease the heart rate. First, number 2, beta 2 is usually present in
Vessel.
arteriole, plus
Vessels.
and venule. So it is usually can cause both vasodilation, arterial and venular vasodilation. So by vasodilation of both the arterioles
But
means the
doctor,
vasodilation.
beta 2 will cause vasoconstriction if antagonized, right?
Yes, no,
Vasodilation.
vasodilation.
Beta 2.
Vasodilation is
Beta
caused
2.
by. Yes,
Agonist,
yes,
yeah.
yes. Beta 2
Agonist
is when
will
blocked, it will usually cause vasodilation. Doctor,
Yeah. I'm trying to.
are you with me?
Yeah.
So, beta 2 receptor blockade will cause peripheral vasodilation in both arteries and venules. Means veins. So, both arterial and venar dilation has to take place with us. And due to these both dilation, there will no change
Stroke volume.
in stroke volume because whenever the the venous return is decreased, there is also decrease in peripheral vascular resistance. So both of these will have the same effect. So the stroke volume will become unchanged with us. Clear? Doctors?
Okay.
So
yeah.
let's move to the option C. Metoprolol is a selective beta blocker which will affect effect on heart. It has to do
Heart.
nothing with the blood vessels. And nitroprusside, as I have already told you
Venodilate.
yesterday, that it is a
That's
venodilator.
both.
Yeah.
And phentolamine, can anybody tell me what is it?
Alpha 1
Al-
agonist.
Antagonist. It is
Alpha
alpha
1
1
agonist.
antagonist.
Oh yeah,
Agonists are
antagonist.
antagonist. It is usually antagonist. Alpha 1 agonist are norepinephrine. We have yesterday told you that. So which option is correct?
Labetalol.
Labetalol, which is a first line drug in hypertensive emergency due to these effects like beta 1, beta 2 and alpha 1 blockade because it is a non-selective. Okay? Clear everybody?
So in which situation then we like prefer the hydralazine?
Hydralazine are usually preferred in any type of like we have to decrease the peripheral vascular resistance like in a condition
Pregnancy,
like pregnancy. Excellent. In pregnancy, which condition?
hypertension,
Eclampsia.
Hypertension.
Preeclampsia.
In pregnancy. Excellent. And which other condition? Can anybody name it? Anyone?
Like if there is any contraindication for labetalol, so alternative can be hydralazine.
So alternative, we can also use hydralazine. Excellent as well. Excellent, doctor. So hydralazine is most commonly used in hypertensive emergency in pregnancy because in pregnancy we usually have to decrease the systemic vascular resistance and we required high cardiac output like we do not required venodilations. We only required increased blood flow through the vessels. So only we have to decrease the peripheral vascular resistance By this mean, we only give the patient hydralazine that will decrease the peripheral vascular resistance. Okay, doctor?
Okay.
Anyone with a question? So we know that the hydralazine is also used in heart failure as well, because the heart is usually present in its compensation stage, and we have to decrease the load on the heart by decreasing peripheral vascular resistance by giving this patient hydralazine. Okay, doctor?
Yes.
And we usually use hydralazine in pregnancy because hydralazine is safe in pregnancy. It has to do and not any kind of carcinogenic effect on the
Baby.
teratogenic effect on the feet baby. Excellent. So by this way we usually use hydralazine in pregnancy. Shall we move forward, or anyone with a question?
No, it's clear. Thank you.
So let's move to the next question. Anyone out there?
Which of the following is most likely responsible for this patient's current symptom? 34-year-old man diagnosed with advanced non-Hodgkin lymphoma undergo doxorubicin containing chemotherapy with a good clinical response. Several weeks after the last chemotherapy cycle, the patient comes to the office with progressive exertional dyspnea. He has difficulty sleeping flat at night and needs to use multiple pillows to fall asleep. The patient is a lifetime non smoker and has no family history of heart disease. Blood pressure is 124/72, pulse is 86 per minute, and respiration are 16 per minute. Oxygen saturation on room air is 96%. Which of the following is most likely responsible for this patient's current symptom?
So the
He has
patient is
taken,
under.
yeah, this disease toxicity, like this doxorubicin, is cardiotoxic because he is
Yes.
taking this
Which
chemotherapy for
type
the
of
heart.
which type of toxicity usually happen? This drug will usually can cause what? Can
Dilated.
anybody?
For dilated
Dilated
cardiomyopathy.
Dilated
Dilated
cardiomyopathy.
Excellent.
cardiomyopathy.
Dilated cardiomyopathy, because doxorubicin are
Cardio.
anti-tumor effect by binding to topoisomerase 2 enzyme in cancer cell that will responsible for DNA cleavage. And as a result of this cleavage will lead to DNA breakdown and lead to cell death. So this is the function of doxorubicin, and it is the most commonly drug that will lead to dilated cardiomyopathy, in which usually the ejection fraction are decreased with us. Okay, doctors?
Yes.
And well, in option B, they are asked about focal myocardial scarring. It is usually occur in which condition?
This Tokosobu myocarditis,
No,
mycardiopathy. No?
it is usually
MI?
occurred
What's
in
MI?
MI.
MI, because it
Oh,
is a
sorry.
focal, a
Yeah, sorry.
single place is usually, and hypertrophic cardiomyopathy, it usually occur in which ejection fraction is usually normal.
Normal. It's a
Uh,
pressure over problem.
And pericardial thickenings and fibrosis are usually occur in which condition? Any type of radiational therapy. Okay, doctor. And restrictive cardiomyopathy is usually occurred in amyloidosis, sarcoidosis, or
Hemochromatosis.
hemochromatosis, and many more conditions as well. Like in radiation, the restrictive cardiomyopathy also occur, and left right ventricular pressure overload usually occur in which condition?
Eisenmenger syndrome.
Which one? It is most common in pulmonary
Right
embolism.
Yeah, PE.
Pulmonary embolism and
Pulmonary hypertension.
Pulmonary stenosis.
pulmonary stenosis as well. Okay, so these are the some of the information related to other options. So with doxorubicin, the most common side effects are dilated cardiomyopathy. Excellent, doctors. So
Is it
anyone with a question?
reversible? Is it
Yes.
reversible? Okay.
No, the dilated cardiomyopathy cannot be reversible. It lead to heart failure. Okay.
Your transplant is the ultimate
The
solution.
transplant, excellent, doctor. The transplant is the only option for end stage. And you should give this patient supportive treatment like ionotropes to increase the heart rate and increase contractility to maintain the blood pressure. So this type of medication should be given to increase the survival of the patient, and the cure is only transplantation. Okay, doctor?
Yes.
So let's move to the next question. Any volunteer?
Okay. Which of the following medications should be avoided while treating this patient's condition? A 23-year-old man comes to the office due to chest discomfort that usually occur during exercise, such as jogging or climbing stairs. The symptoms go away 5 to 10 minutes after he stops. The patient has not had syncope, but mentions some short of breath that accompanies the chest pain. Family history includes an uncle who died suddenly at age 35. Blood pressure is 120 over 70. Pulse 70. Apical pulse is strong and sustained. While spine, the patient has a soft decrescent systolic murmur at the apex and the left sternal border. It becomes quite pronounced when he stands. Which of the following medications should be avoided while treating this patient's condition?
So the patient has a family history of some condition that usually can cause sudden death in his uncle at the age of 35. So a 23-year-old man come to the office due to chest discomfort and exercise such as jogging or climbing stairs. So we know that the MI is very uncommon in younger individuals. So we should think for something else. So let's move. While jogging, the symptoms will go away for 5 to 10 minutes after he stops. The patient has not had syncope but mentioned that he has a shortness of breath and accompanied by chest pain. Family history of his uncle who is died suddenly at the age 35. Blood pressure is normal 122/70 and pulse is 70 per minute and regular. The apical impulse show a strong and sustained, means that there is some type of hypertrophy usually occurred which will increase. So can anybody tell me what is the condition here?
Hypertrophic cardiomyopathy.
Yeah.
Excellent.
Tom.
Hypertrophic cardiomyopathy, and there are some condition in which it is usually occurred, in which a mutation take place in a sarcomere, and it is a autosomal
Dominant.
dominant, mean a single mutation in a gene can cause it. So what happened in hypertrophic cardiomyopathy? Usually, I'll have to draw a heart for you here. So these are ventricle atriums, and these are ventricles with us. Okay. So this is ventricle with us, and in this condition, what happened with us that the septum is usually increased with us. So this is the normal heart. Let me draw it for you. I have make a little smaller left ventricle than the right ventricle. Normally the left ventricle is little bit bigger than the right ventricle. So this is the hypertrophic cardiomyopathy. Sorry, and let me. So this is the hypertrophic cardiomyopathy in athletes. Can anybody tell me why in athletes?
In strength,
Anyone?
usually there is a
Yes.
atrophy of the left
Yes,
ventricle.
due to excessive
Concentric.
exercising, but
Yes, pressure a lot.
in athletes there is a uniform hypertrophy.
Concentric.
And
Yeah,
yes,
concentric.
yes, concentric hypertrophy, but in hypertrophic myopathy that is usually occur in young individual due to autosomal dominant disease is usually eccentric, means that the rest of the septum is usually increased, and we know that this septum will block the left ventricular outflow tract, means that aortic stenosis
Stenosis.
usually caused by this septum. This septum, when contraction, this septum will come near, these walls will come together, and as a result of this, the left ventricular tract will become obstructed. Left ventricular outflow tract obstruction is similar to that of tetralogy of Fallot, in which there is a left ventricular tract obstruction take place.
Right ventricular.
Yes. So, right ventricular tract obstruction, because the overriding of aorta occur in tetralogy of Fallot. So, due to this left ventricular outflow tract obstruction, whenever a patient is usually exerting, it will decrease the blood flow through the aortic wall, increases, and the patient experience chest pain and shortness of breath. And whenever the exertion is increased from its limit, it can cause sudden cardiac death due to myocardial ischemia or MI. Clear, everybody?
Yeah.
So we have to avoid in this patient any type of medication that will decrease the venous return, because the
Yes.
patient has already have decreased amount of blood flowing through aorta.
Yeah.
So whenever we have to decrease this venous return, the blood will eventually decrease more, and this will lead to cardiac ischemia, because we know that the cardiac muscle are the only muscle that will use 70% of its oxygen supplied to them. Okay, doctors?
Okay.
So due to this, we usually avoid those type of drug that will decrease the venous return with us. So in the above option, which one of the following drug is venodilator?
C. Vasodilator.
Yes, I will
Excellent.
dilate it.
So we have to avoid these drugs because this drug will cause venodilation, and venodilation will cause the condition worse with us and will also lead to sudden cardiac death of the patient. Okay, clear everybody?
Yes.
So let's move. Anyone with a question? Anyone? Shall we move forward?
Yes, please.
Yes.
So let's move to the next question. Any volunteer?
Which of the following best accounts for improvement of this patient's symptoms? A 25-year-old man comes to the office due to shortness of breath. He states that even moderate exertion forces him to stop to catch his breath. The patient has no family history of sudden cardiac death. He does not use tobacco or illicit drugs. On examination, the patient has a faint systolic murmur at the left sternal border in the supine position that increases to 3/6 in intensity with Valsalva maneuver. Echocardiography shows interventricular septal hypertrophy and increased left ventricular mass. The patient is started on high dose beta blocker therapy. On follow up 2 weeks later, he reports significant improvement in shortness of breath. Physical examination reveals no murmur supine or with Valsalva. Which of the following best accounts for improvement of this patient's symptoms?
So they are actually asking about mechanism of action of beta blockers. Okay, doctor?
Yes.
So can anybody tell me how beta blocker usually work? Anyone?
Decreasing the conduction velocity and firing, and by that,
Yes,
yes, it can increase the left ventricle preloading.
yes, and also with reduction of heart rate, there is also
Reduction
decrease
in
in
the oxygen
Contraction.
consumption. Yeah.
contractility. So which option is correct?
C.
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 C option. Clear everybody? Anyone with a question?
Sir, does beta blocker reduce the left ventricular preload?
Increase, right?
Increase
Because
I,
give more time.
I'm asking, does it reduce the preload beta blocker?
beta blockers. Can you go again, doctor?
Can beta blocker reduce the left ventricular preload?
Decrease the flow velocity. Beta blocker will tend to decrease the. Let me.
Option E, sir. Option E. Does beta blocker do that?
No, beta blocker will increase the left ventricular preload, not decrease. Okay. it will increase the preload.
Okay.
Medication that decrease the left ventricular preload are nitrates and diuretics. Because nitrates will cause venodilations and diuretics will cause decrease the overall fluids with us. Okay?
Thank you.
Clear?
Yeah.
So
Yes.
let's move to the next one. Any volunteer?
Initial empiric treatment should include which of the following antibiotics? 62-year-old man who underwent mitral valve replacement 1 month ago is being evaluated in the emergency department for low-grade fevers. He has some malaise and dyspnea. Multiple sets of blood cultures are drawn, and within hours, all bottles grow gram-positive cocci in clusters that are catalase positive and coagulase negative. The decision is made to begin an empiric antibiotic therapy. Initial empiric treatment should include which of the following antibiotics?
So, can anybody tell me that which one of these bacteria? Anyone?
Staph aureus.
Yes.
Have
Aureus. Sorry.
Staph
Staph
epidermidis.
epidermidis.
Staph
Excellent.
epidermidis.
Coagulase.
Because it is a catalase positive and coagulase negative. So
Negative. Yeah.
let us discuss that why staph epidermidis will usually cause such effect. Staph epidermidis has a specific type of polysaccharide called glycocalyx. Our glycocalyx, this glycocalyx will attach to the smooth surfaces of any material. So this patient has underwent a mitral valve replacement, and we know that staph epidermidis are present in abundant on skin. So they have a very due to this polysaccharide glycocalyx, they are attached to this type of mitral valves and can cause endocarditis. So what is the first line treatment for staph epidermidis? Can anybody tell me?
Vancomycin.
Vancomycin. Can anyone with another option?
Ceftriaxone.
So ceftriaxone. So ceftriaxone is little bit a broad spectrum. It can be given but not
Ciprofloxacin.
a drug of choice. So yes, doctor?
Ciprofloxacin.
Ciprofloxacin is very much for gram-negative rods.
Gram-negative. Yeah.
UTI, right?
Gram-negative rods.
Then
Like
penicillin.
UTIs. UTI,
Then
the most
penicillin.
common bug is, can anybody? In
E.
UTI,
coli.
the most E. coli,
E.
which is a
coli.
gram-negative rod. And clindamycin can be used in
Acne.
Anaerobes.
Don
Anaerobes.
anaerobes above diaphragm.
Above the diaphragm.
Okay.
And below diaphragm,
Metro.
which
Nitro.
metronidazole. Metronidazole. Below diaphragm, anaerobes can be treated with metronidazole, and above diaphragm can be treated with clindamycin. And nafcillin, can anybody? It is usually a
Gram-positive topical.
Gram-positive.
gram-positive and can be used against staph epidermidis as well. And penicillin G have the same effect, but we know that about 80% of the strains of staph epidermidis have a methicillin resistant.
Mm.
So now we go with the first line medication, vancomycin.
Okay.
So vancomycin is a first line drug nowadays used in staph epidermidis because we already know that 80% of these strains are methicillin
MRSA.
resistant. So
Yeah.
we doesn't use in this patient nafcillin. That's why we will go with which option?
F.
F, vancomycin. Excellent. Clear everybody? With the all the above options, that which one of the following medications is used in which condition?
Clindamycin.
Yes. So let's move to the next one and the last question of today's session. Anyone?
Okay. Which of the following is the best next step in management of this patient? 56-year-old woman present to your office with chronic cough. Okay.
Sorry.
She says that the cough is dry and affects quality of her life significantly. She denies chest pain, hemoptysis, and shortness of breath. Her past medical history is significant for long-standing hypertension, diabetes, and myocardial infarction experienced 2 months ago. She does not smoke or consume alcohol. Her blood pressure is 130 over 70, and heart rate is 70. Which of the following best next step in management of this patient?
So can anybody tell me which one of the following option is correct and why?
E, due to inhibitor.
Please do the chest X-ray first, right?
So anyone with another option?
Check the current medication, maybe,
Why?
because we want to know what
So
medication
she's
is
taking
normal.
Side
Right.
effect of medication
inhibitors.
like ACE inhibitors.
Because the patient
Excellent, doctor. Excellent. So the patient, the woman presented with a chronic cough and she denies chest pain, hemoptysis, and shortness of breath. He has a past medical history significant for long standing hypertension. Clear, and the patient also has diabetes and a myocardial infarction experienced 2 months ago. So, as we have already discussed, that the patient with diabetes mellitus, the best medication is ACE inhibitor, and we know that ACE inhibitor can cause dry cough.
Yeah.
So we have to clarify about her medications, that why that either she is using any type of ACE inhibitor in her medication or not, because the dry cough is one of the side effect of ACE inhibitor and she is presented with chronic cough. Okay.
Yeah.
Yes.
And after, because first come history, and after history you should go with examination, and after examination,
Investigation.
so first come history, and after history come examination, and examination you should go for differential diagnosis, and after differential diagnosis you should go for investigation. So all of these will come in history and this will come in investigation. Okay, doctor?
Okay.
Yes.
Oh, okay. That's the last
Okay.
step, right?
Yes. So this is the last step. Just X-ray. If we doesn't find anything on examination, on history, and then on examination, and then on differentials, and then we will go for investigation. If we found something on examination, then we will do an investigation to confirm it. We will do an investigation most probably for confirmation of something, that it is 100% confirmed with us that either it is present or not. Okay, doctor?
Okay, thank you.
Doctor.
So this is the last question of today's session. Anyone with a question in all the above previous questions? Anyone?
No. Doctor,
Anyone?
that channel, the other, not the ENAC, Romic, I forget RO. There is another. The
Another
RO.
what?
That when you give the ENAC the
Romac,
potassium. Yes, Romic.
Let me clear it first, this MCQs. So now you should go with your question once more.
Yeah.
I
When you
can't.
when you talk about the eplerenone or which one, I forget which one of the diuretics and the ENAC, you said there is another, the RO, I forgot the name. I think Hussein now said.
Triamtrene and imidazole. Both these are act on ENAC and inhibit it. And spironolactone and elipronone will act on aldosterone
receptor
and inhibit it.
Yeah.
So aldosterone are responsible for production of ENAC. So whenever the aldosterone is not present, the ENAC will not form. And whenever, because aldosterone are responsible for much of the different effect as well, normal effect as well. So spironolactone and elipronone have other effect like gynecomastia as well, this type of effect as well, while the triamtrone and the spironolactone have other effect like sodium excretion that can cause hyponatremia with us as well. So these type of side effects are related to spironolactones and elipronone. That's why we should go with options like triamtrene or amiodarone to that we are not required to antagonize aldosterone. The aldosterone will function normally. We only inhibit this type of ENAC channels. Okay, doctor?
Okay.
Clear now?
Yes, I think. Inshallah.
Anyone with other question?
I was thinking eplerenone doesn't have that side effect of gynecomastia.
Yeah, it doesn't have.
Spironolactone,
It doesn't.
spironolactone has a very much side effect, like very much greater effect of gynecomastia than elipronone. But elipronone have a little effect of gynecomastia because it also inhibit aldosterone. That's why a little, not that much. Okay?
Yeah, thank you.
Thank you.
Welcome. Anyone with the other question?
Someone was saying, is it amiodarone or amiloride?
Sorry.
It's
My writing,
amiloride.
it is amiloride.
Amiloride.
Amiloride. Okay, doctor. I have a little bit spelling mistakes here.
You're exhausted.
It's okay. We understand.
Yeah.
Sorry, this is not
Thank you so much.
Welcome.
I have a
So,
question, sir. So,
yes.
given having gone over many mechanisms of actions, all these antihypertensive drugs, like what makes us decide and pick the drug of choice for certain conditions? Like, is there any guideline you can give us to follow?
There are some guidelines like American guidelines are the most important and usually followed by USMLE, but these guidelines are most common in step 2, not in step 1, because it will travel your mind towards step 2, and step 2, I think you should only focus first on step 1 and then on step 2. Okay, doctor? These
So
type
for
of
now,
side
we just
effects.
need. So just for now, we just need to know the mechanism of action,
Now,
right?
now,
This
now
one?
you should only on pharmacology for step 1, you should focus on mechanism of action of that drug, uses of that drug, in which condition we usually use this, and in side effect of that drug. These are much important topics related to step 1. So
Yeah.
when different types of, so they doesn't give you different type of medications, like in heart failure either we use furosemide, either we use um, thiazide diuretics, either we use spironolactone. So in patient with compensated cardiac failure we use spironolactone because it have a much beneficial effect on a heart, like antagonize aldosterone. But in acute stage we use furosemide because first we have to decrease the fluid overload, because furosemide does not have a long term survival rate, it has only to decrease the fluid overload, and after fluid overload we switch to spironolactone because it has an increased lifetime. That's usually come in step 2 types of question, not in step 1. Step 1 they will basically give you a single um, clue that either these drugs will cause which type of side effect, like in we have discussed earlier, like in hypertrophic cardiomyopathy we cannot use in a patient dilators that will decrease the venous return. Okay.
Okay. So for antihypertensives, like we learned those many mechanisms. So like how to decide, are we going to give like a potassium sparing drug or a calcium channel inhibitor, or like are we going to give inhibitors? Like how do we decide, like for clinical
so
purposes?
so there are some side effects, like let me tell you that. So in a condition like in a condition we already the first line medication in a patient with diabetes mellitus, or in a heart in diabetes mellitus we will go with, first with diabetes mellitus we will go with ACE inhibitor because it is cheap one, and after a patient that has to develop some kind of like side effect we will switch to ARBs. Okay. So the
Okay.
patient, the beta blockers is usually contraindicated in those individuals which have some type of asthma or bronchospasm. Because can anybody tell me why?
It's
It'll
mimicking.
exacerbate the situation.
Excellent. That will
Breathing.
exacerbate the situation.
Yeah.
These are the some of the drugs in which condition we use beta blockers and in which condition we use beta blocker. So ACE and ARBs are usually used in CKD patient because in CKD patient we have to decrease the renal perfusions. So these will the efferent arterial vasodilations and increase the GFR with us. So they are used in CKD as well because of a renoprotective effect. Okay, doctors.
Okay.
Yes.
Any other
So
conditions like this that would help us like navigate what to decide, like what to give?
so in condition like in heart failure in individual greater than 65 years, we usually go with calcium channel blockers. Are usually a you should start from ACE inhibitor and then ARBs, and then start a combination of these drugs can be like in ARBs we can most probably give another drug like thiazide diuretics, which will come under the name of Covaltech. So this thiazide and valsartan will eventually decrease the heart rate with us. Clear, doctor?
Yes. Yeah.
So it is
And also,
most probably associated with step 2.
Okay.
sir,
Right.
to like help Dil, I just want to add one more thing is that American
Yes.
Heart Association, it is the one which every year it publishes the protocols, and every physician in USA they usually follow that protocol. You can go to the website and just see that
Oh, okay.
Yes. So
yes,
let
What
me
is it? What's the website?
if you gonna
Mm.
uh like we have to, because every time there are studies that is going around with every patients, and they will go through a trials of different types of medications, and they will try to give the best medication to the patient. So every year they are usually decreasing the medication. So generally in essential hypertension, can anybody tell us what is essential hypertension?
idiopathic
It is
hypertension.
Yeah, idiopathic when
idiopathic
there is no
hypertension in
known.
which there is no known reason behind the hypertension, in which in this we usually go with these 4
Age.
drugs. Like in thiazide diuretics, you can give them thiazide diuretics, you can give them ACE inhibitor, you can give them ARBs, and you can give them calcium channel blockers. You can give them any of these 4 in this individual. Okay,
Oh, that's okay.
there.
Okay.
So
Yeah. Clear.
let's move to the next one. So a
Okay.
patient with hypertension with reduce ejection fraction, and the patient is also hypertension as well. So we will give with either ACE inhibitor, either ARBs, either beta blockers, like beta blockers. I have already told you in the previous MCQs that the hypertensive medication in reduced ejection fraction, we will give beta blocker, ACE inhibitor, ARBs are potassium sparing diuretics, and only one medications like furosemide only if there is a fluid overload. Okay,
Okay. Okay.
to decrease the fluid overload. And we can also give this patient hydralazine and isosorbide nitrate, because hydralazine will cause arterial vasodilation and decrease the load on the heart, and also sorbide nitrate are also venodilators, and it will also decrease the load on the heart. So these are the following medication which is usually given to the patient with reduced ejection fraction and a patient with hypertension. Okay, doctor?
Okay. Yeah. That's
So
exactly.
let's move to the
Thank you so much.
other hypertension. Wait, doctor, there are so many drugs still remaining.
No problem. No
So,
problem. Thank you.
so patient with stroke. We read an essential hypertension. We read heart failure patients. Now, patient with a stroke and hypertension, we usually give with ACE inhibitor, or ARBs, or thiazide diuretics. Okay, we cannot give these patient calcium channel blockers, we cannot give them beta blockers. We usually give them either ACE inhibitor, ARBs, or thiazide diuretics. So the hypertension patient with post MI. So which type of medication usually give in them? When a patient with MI is usually a hypertensive as well, we can give them first line beta blocker, usually a selective ones like carvedilol or metoprolol, and we can also give them ARBs and ACE inhibitor. And also the third one is calcium channel blocker. So these are some of the medications that are usually given after post MI.
Okay.
Okay, doctor. And hypertension with CKD, as I have already told you, you can give them ACE inhibitor or ARBs. These are the choice for diabetes and CKD as well. Clear?
Okay. Yes, sir. Clear.
Clear with every medications, like with essential hypertension, with
Yeah.
diabetes mellitus, with stroke, with reduced ejection fraction, with post MI. So these are the medication that we usually give the patient with some of these complication. Based on the complication, we will prescribe them their medications. Anyone with the other question?
Thank you so much, sir. Then thank you, Sen, for helping me out. Appreciate it.
Welcome. Yes.
But before leaving, I just wanted to ask a question. Will there be any class tomorrow? Or
So the pharmacology will be ended today. So I will talk to Dr. Hashim. So he will tell you in the group that either tomorrow there will be any class or not. Okay.
And sir, do you have any idea, like what are we gonna do on the next class? Which subject are we gonna do next class?
I have literally no idea. So I am ask them that which system they gonna
Yes, sir.
explain
Yes, sir.
it to you. Okay.
No, sir. I was just asking. Yes, sir. Thank you so much, sir. It was a huge.
Welcome.
You made it so easier, the all the medications and everything, and pointing out the the specific thing that we should focus on. Thank you so much, sir.
Welcome. So thank you so much for attending the class. Thank you so much. Have a nice day. Bye bye.
Thank you so much, sir. You too have a wonderful day.